Yeah, we only get everybody together for so many hours once a month, and we just have to do our required stuff. And so, I think avenues for doing podcasting and other things not to be a great adjunct because inevitably, too, as a paramedic, you need all that stuff that your agency is providing, but it's also, I just had this really challenging patient 2 shifts ago, and the ED doc said this is what's going on. I want to learn more about that. And so people
Hey, is anybody else on with me, or am I all on my own here?
We're with you, Paul.
Okay, good. Let
Hello.
me then turn this other thing off. It keeps going on forever and ever. Okay.
Glenn, you're still alive.
Yes. Oh,
Okay, I'm back. Let's see if I can get volume on now. Here we go. Who is this guy, Glenn guy? Who is that? I haven't seen him for a while. He's been at the Western White House for quite a bit, right?
whew, I tell you, it's been crazy. Day 5 of the strike, and it looks like it's going to go for another couple of weeks. So, 15,000 nurses, 10 hospitals, 3 of the major networks.
So has that had clear-cut, straightforward, holding you up kind of issues the last
Well,
couple,
we've been preparing, quite a bit, and it's not like we can get more ambulances out there because we don't have the personnel. We also don't have the ambulances to put them into.
yeah.
But luckily, knock wood, our call volume has been lower than it usually has been. We did put a
Ah,
campaign out to say, listen, that during the strike, you may call 911 for real things, and that usually backfires. We get more calls, but it's
right.
holding
The
out at the moment
classic.
because it's like, oh, I could call 911 and the volume goes up. But so
Yeah,
far, it's
right.
holding. Negotiations don't seem to be going well. The hospital claims that they want their nurses, legitimate things. They want safety, right? More security getting into the building. The ratio of patients to nurses, of course. They also want something about their health care benefits. Absolutely. The hospital's claiming that they want their salary, the average salary for a nurse, to be $250,000. I told my docs, let's go and become nurses because they're making more than us. So that's I think the sticking point. The 3 networks have told us that they're just not going to, budge now because they said every 3 years this happens and they're not. And so they have travel nurses that have filled the spots now. But
Yeah.
negotiations have not been going well. We're constantly on a state meeting. Matter of fact, I'm leaving at 12:30 to get another state meeting.
Yeah.
And our New York City emergency management meeting is going on, and we have our internal meeting as well. So it's just been nothing but meetings. We're keeping track of diversions. We're keeping track of turnaround times at the hospitals. We're keeping track of our response times. And knock wood, it's been okay. But at some point, it's going to hit us.
Yeah, I'm sure. Yeah. And are the call volumes on because it's cold out, or what's going on that
Yeah,
end?
we expect today it dipped down into 20s last night, and our volume should be a little bit lower because of that. But the
Classic.
last
Yeah.
couple of days, we were shocked on Monday, the first day of the strike. Mondays, as you know, nursing home patients and such, we were expecting a huge number, but it actually held below 4,200, which is unusual for us.
Yeah. So it's interesting. It's cold everywhere. Even here, it was like this morning. It was in the 30s here in Fort Lauderdale, which is wild.
Wow.
But clear
Wow, wow, wow.
skies. It's been beautiful here,
Yeah, yeah.
but cold. Yeah. I don't know how long it's going to last, but we're supposed to get another blast as well. It's a
Right.
little unusual. So good. And how about snow? Are you getting any precipitation there?
We're told tomorrow we're supposed to get something, but just a trace is what I'm told.
Okay, got it. Okay. Well, anyways, that's always becomes a problem. I remember years ago in 1993, I was running around with a group of people called the New York EMS, right? And they said we're gonna have a snowstorm tonight, apparently. And and I said, okay. And they said, so you might want to come out, Doc. You might have a bus crash or something like that, right?
Yeah.
That was the night they had that Fokker. The U.S. Airways went into the drink there over at Flushing Bay. That was quite a night for me with your guys, but they were all great. It was really kind of fun. But also interesting lessons learned from that one too. But so whenever I hear a little snow showing up in New York, I always think about that. Or the
Right.
time I was up there visiting, right? And I met with Cherie, that kind of thing. So.
Yeah.
Okay, well, listen, I think we're getting an accumulation of folks here, and I'm trying to get everybody moved over to the panelist side of things. We'll see how that goes. Not doing extremely well, but whatever. So, the first thing I had on the agenda would be they just ask, is anybody um, Hey, Keegan, I've been trying to get you over. I don't know if you're moving or not. Same thing with Kevin, but I've tried that. Um, I
I made it
see.
over, Paul.
Okay. Well, no, it was Kevin Joles that I'm trying to get over. That's why. And
The
Keegan Bradley,
the
yeah.
other Kevin. Gotcha.
Yeah, the
Yeah,
other Kevin.
we
Yeah, that's
affectionately refer to him as Kevin number two.
Oh, okay. Good to know. Keep that in mind. I was not aware of that, but I'm learning something every day, so that's great. Hey,
I'm
good to
over
see
now,
you, by the
Paul.
way. Huh?
I'm
What'd you
over
say?
now.
Good, Keegan. Thanks a lot. And because I want you to bring up the interesting question you brought up to me yesterday. I told you my answer, but let's see what everybody else says, right? Okay. Well, I tried Kevin number two coming over, but I haven't done very well. Hey, Bill, I just saw you pop up there for a second, and were you able to work out that thing with the CME? Did I send you the right information?
Yeah, worked out great. It very efficient and very impressive CME operation.
Yeah, yeah. Okay, good, 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 good. All right. Yeah, we've been very fortunate to have that, and it's quite a bit. I mean, I probably collected something like well over just from this thing alone about and the thing I run the half an hour before that with Florida, probably I probably accumulated 80 hours of CME and all that. I'm going to do something different this year, which is I'm going to try to see if I can keep track of what we're doing every week and see if it applies for various things. So, for example, in California, your license might need an hour of end of life, stuff. And so, if we talk about, termination resuscitation or whatever, we can maybe say, hey, I can validate that, yes, during that, as the course director, we did provide end of life education that was category AMA one, the kind of thing. So, I'll see about that, etc. So. All right. Hey, and I'm recertified. I'm very proud to say it's now the new year, and I'm recertified for another 5 years in both EMS and EM. And I think we talked about this a few weeks ago about all the issues with what it's changing now, where you have to pay a fee every year to them and all that. And so, if anybody wants to learn more about that, again, come back to me, and I'll be glad to go over with them now that I've become sort of pseudo expert on it, having gone through the process and trying to learn what I have to do next. All right. So, with that, let's go ahead. Meg, you're on. Do you want to do your real brief presentation? Anybody, by the way, for anybody here on right now that has to get off pretty soon? I know Art, you have to get off at 11, right?
Yes, sir, but I'm just a fanboy today.
Okay, got it. Oh, but I'll tell you what. Hey, Meg, are you okay time-wise if we wait a little bit? Because I may want to, since are you're there now and you're okay, Brian McNally, right? Are you on with us?
Yep. I'm ready.
Let's go ahead because Art's got to get off, and since Art is the person help you get this thing started in the first place, I
Yep.
just thought I'd like to give you the sort of a chance to come on and just make sure that everybody knows that who you are and what a terrific asset you've been to the planet, let alone us here in the United States, etc. And I'll have Art do a real quick introduction of all that, if you don't mind,
Yep.
and of you. And then what I want to do is there's a couple questions that came up, things that have been raised to me. And you see, I had Scott Youngquist written there, and that's the reason he brought up some things about the past about having, like in the registry, having time to CPR, time to the shock, etc. And that may be very hard to do, or even impossible because you can't rely on people's whatever. But all those things I think are such important matters, and he's brought that up to us in the past. So I'll just throw that out. But one thing that came up yesterday that was interesting, and so address it after we get the intros done, is Keegan Bradley from our Arlington shop, so to speak, brought up the issue about now that we're giving blood. So you get a person who's got the Utstein, criteria, right, of witness, bystander CPR, VFib, right? But they're getting blood for their GI bleed or their obstetrical bleed. Do we put them there, or do we now that this is in my opinion, a separate treatment, right? Should that go in a different bucket, etc.? So I'm just thinking about the other buckets for the bleeds, that kind of thing. And the reason also I say is because currently, why do we even look at Utstein, or so we could actually compare for other people if you're doing, this. But now if we're adding this new therapy in there, should that go into a separate bucket? That's what I said to him. Keegan Bradley, did I articulate that correctly?
Yeah, that was perfect, Paul. It's been interesting, between you and some of the other medical directors I'm in touch with, it's actually been a very 50-50 answer. Some people are like, absolutely, that makes sense. Some people are like, absolutely not. That just throws off all our data. So, you have a good question when 50% disagree and then 50%
Yeah.
think it's a
Well,
great
my
idea.
my opinion is, we'll see what everybody else says. My opinion is that you're doing that for apples to apples comparison. I'm not doing as well as that city, or I'm not doing as well as the national average, et cetera. So that's why. But if I got blood in there now, that kind of thing, and maybe you could say how you would like that and how you've done that in the past. Brian, just to know about that one. But before we get into the details of that one, which is what brought me up, is that how have you been liking the cool weather in Fort Lauderdale? He's in Fort Lauderdale with us this week.
Yeah, it was a little chilly on the run this morning, and I'm glad you said it was 30s because I'm thinking if this is 40s, this is really bad. But
That's great.
yeah.
And are you going to be okay? Can you get together tonight?
I'll have to text you because I think we may have a reception, but we'll let you know. But
Sure, or we can go
hope to
after the
connect.
reception or whatever it is.
Sure.
Okay, so this is good. All right. So let's go ahead. If you don't mind, can you give us a historical perspective, Arthur Kellerman, right? Who at the time, I believe, was the chairman at Emory. Is that correct?
More or less. I don't remember if I was the chief or the chair then, but that was 20 plus years ago. But I'll just do it super quick, Paul, because I want to give Brian and the rest of the folks a chance. So some of our best ideas in EMS, I think, come out of arguments. And that was the case with CARES because at the time, one of the local affiliates for AHA was very excited about a donation, and they were going to basically sprinkle AEDs. Remember, these are the AEDs of 20 plus years ago
Yeah.
across Atlanta, and it was going to save a lot of lives. And I said, how do we know that? We don't have the data.
Yeah, for a second. Hey, Jim Augustine, just so you know, you're live and we're hearing your radio. Okay, but go ahead. Go ahead.
They flew folks into Atlanta. We had an airport meeting. It was sort of me on one side of the issue and a bunch of folks on the other side. And this guy was sitting in the corner, kind of very quietly, didn't speak, just listening, who turned out to be George Mensa, who at the time was working at the CDC, and then later went to NHLBI. And I just said, you'll never know. And if you don't know, how are you going to sustain the program? How are you going to know where to put these devices? How do you know whether they're making the difference or not? We need adequate data. Most systems in the country, with rare exceptions, Seattle being one at the time, don't have the ability to measure their performance, focus on where to improve it, and use that tool. And so we respectfully disagree. About a day or two later, I get a call from this guy, Mensa, and he says, we really like your idea. We'd like to do a pilot project. If we were able to do that, do you think Emory could help pull it off? And of course, I turned to a relatively new faculty member at the time, Dr. McNally, who had come out of New York EMS, and said, Brian, this isn't going to be an easy lift, but what the hell? Let's give it a try. CDC wants to chuck some money this way. It was run through the AAMC. It was clearly earmarked for Emory. We started with Grady EMS, Atlanta 911, and Grady Hospital. Those were the three original participants. I never, ever, in a wildest dream, would have imagined that it would become the de facto national registry today, that it would ultimately get unanimous House and Senate support for federal supplemental funding at a time when the House and Senate can't name a post office, for God's sakes. And that brings us to where we are today. But so it was a joint idea of Brian and mine and a handful of folks in Atlanta.
Yeah.
But
and
Brian is the guy.
Jim Augustine was around at that time as
Yeah,
well.
Jim
Right?
Jim came up. Jim came, I think, Jim a little bit later. I don't recall, and I may be at a point in life where you sort of the details get blurry.
Yeah.
But we had and they have an extraordinary group at Emory. But I really want to give credit to Brian and the team he's put together. I got re-involved a few years back, more or less again as a fanboy at this point, but a collaborative effort. We engineered it from day one to be as simple and easy to do as possible. My favorite Dolly Parton quote, or at least attributed to her, was once, you have no idea how much it costs to look this cheap. And my paraphrase for that with CARES was, you have no idea how hard we worked to make it this easy.
Yeah,
And
that's
that's
great.
what's made it functional, because EMS folks don't have a lot of time to be pumping things into computers. Fire chiefs don't necessarily have the wherewithal to put together data analysts and come out with customized reports. And this whole system has functioned on that basic premise.
Yeah.
Easy, focus on the critical things that matter, and do it not for research, not for some intellectual pursuit, but to improve performance, improve
Yeah.
survival, and gain insight. So, Brian, you got it.
Before we turn it over to Brian, I've got to say a couple of things. One is you got to see what Terry threw in the chat, and it becomes relevant because you heard Art talk about maybe it's only one place as far as was measuring this, and that's because in the 1970s, Art and Terry and I were some of the offspring of the Seattle system at the time, and so just really kind of in very close to Dr. Kopis and yeah, and Hudson and the rest, and so just very, very cool to
Yeah, we were very lucky. Great
have
confluence
that
of folks.
legacy, and that's part of the what you're seeing going forward. Now, having said that, and you made the comment about this has exceeded your expectations. A lot of that is because of the, quite to be blunt, the interpersonal skills and the brilliance of Brian McNally, who we have on now, who's the current executive director there. And it's just been a pleasure to work with him and see how effective he's been to get things done. And we're still, like the other night, we're just searching new ways of finding out different ways to say, where do we place those AEDs, right, Brian? And do it through research, etc. So with that, do you want to take over and switch over? There you go. Thanks a lot, Brian, and welcome to our show. That never ends. Okay.
Thanks. Yeah, and I recall the three of you with Terry were the three amigos. Is that correct? I think I heard that term somewhere before, but it's
Well,
great.
we were Trace at the time, but
Yeah,
Exactly.
yeah. Well, thanks, Art, and thanks, Paul. Two things I want to say related to the project starting. One was Art obviously helped recruit me to come to Emory, and I remember this, and I've told him this before during the interview. Basically, towards the end, he said, if you come to Emory, we'll help you develop your career, and that's exactly what he did. I mean, he really has mentored a lot of our faculty, and I want to point out that this project really never would have happened without him having that conversation or opening the door. And he's been involved from the project from the beginning, not just helping with that conversation, but actually helping getting the project started. And he made the point early on when we were beginning to look at what data elements we're going to collect. I remember it said KISS principle. Let's focus on KISS principle. And I think really important, focusing on quality. We weren't going to collect all assessed patients. The idea of let's not make this a death registry. Let's make this a resuscitation registry. And I think, that is, but one other footnote that he may not remember was this is the first grant application I was involved with. And literally about 3 days before we had to submit it, I was getting final feedback, from the research office. And somebody called me and said, the application that we gave you, it's not the correct application. You filled out the wrong application, right? So imagine, so I had to go through and cut and paste, basically these questions. We still got the grant. So we got very lucky. But that door really needed to be opened. And Art really, career-wise, he helped, and he still helps today, but helped me recruit, but also really helped get this project off the ground and has helped throughout. So really want to thank him. It's been a team effort. And,
the cool part was that this was originally started out to see if this is going to work in your regional area. Then we start taking it to, across the states, et cetera, in the United States, and you're around the world now. I mean, that's one of the reasons why you have a house in Vietnam. Is
Paros.
Paros is, and that's a separate story too, again, about opening a door where literally, for those that may know, a colleague in emergency medicine in our department, Camilla Sasson, who does a lot of work with Heart Association, for those that may know, she was a resident at Emory years back. She was coming to a CARES meeting at NMSP 17, 18 years ago and bumps into a colleague in the elevator from Australia and invites him to the CARES meeting. And he says, hey, could we use CARES in Sydney, Australia? And we said, well, don't really know about that. Haven't thought of it. Met with him the next day. And he said, hey, we're working on this project called Paros.
Yeah.
They were about 4 years behind. And that led to back then a Skype conversation before
Oh yeah.
GoToMeeting and emails. And Marcus Ong, for those that know, in Singapore.
Yes.
They were doing what we were doing, but just about 3 or 4 years behind. And we agreed to meet at a meeting in Valencia, Spain. It was a conference. We never went to the conference. We met at the hotel bar and we sat down and said, if we're going to collaborate, we need to make sure we've got apples to apples. And that's really where we started to look at data elements and then met over the next few months. And that's really the birth and the relationship between CARES and Paros. And we're still working with that group today. So it's been a great opportunity to collaborate internationally, but obviously all the domestic lessons learned, and a lot of this is about measuring and improving. It's a global, a global condition. Clearly, most of the world is not collecting data where most of these arrests occur. I think that's something to realize, right? The majority of the population of the planet is not collecting data specific to out-of-hospital cardiac arrest. But that's changing. There's countries, India's talking about a registry, Pakistan's talking about a registry. Europe doesn't have a consolidated registry, but has, country specific. So it's been, it really goes back to Art's keep it simple. Keep it simple, not nice to know questions, but need to know.
Yeah. So, in the event, at this point in time, so I can get onto some of the other topics, I just wanted to, welcome you to the show and come as often as you can. And we may pose questions to you or may want to end. But what I love is that you've seen how successful it's been for us here in Florida to adopt it as a statewide program and have it, it's just what you do at the state. And have great leaders like Devo doing it, right? And you get to see him tip last couple of days. How's he been? Okay.
Yeah, it's great, and there's been great work, as Paul mentioned, in Florida, and particularly the not just the measurement piece. And Tom DiBernardo is the state CARES coordinator, and the support, of Ken Shepke, Paul, and others, Jim Augustine, that are really sort of a powerhouse in terms of advancing cardiac arrest, resuscitation care. From not just turning on Florida Cares, but they've been doing resuscitation academies here for many years. I was invited several years back, and I was really amazed at that time how much enthusiasm there was and really how that's expanded, right? They've developed budget to have resuscitation academies across the state. They've also advanced telephone CPR education and quality improvement. Just sitting with Tom for an hour for lunch the other day, I just wanted to take notes of all the things that really have happened here. So it's been really interesting.
And the reason why I'm bringing that up is I want it to be a model for some others that haven't been able to pull this off as well. A lot of people have pulled off amazing things in other places and even better than ours in some respects. But what was kind of cool is to have Ken Shepke, who was an AMS-oriented guy, become a deputy secretary of health and just help push this to the right. So at the state level, it just become a real powerhouse in terms of both uniting CARES with Resuscitation Academy. So that's been really good. All right, so let's get down to the practical thing. So you heard Keegan's question, should I be putting this in the registry if I'm giving blood to this case because they present with a stain, but it's a non-traumatic case. So what's your, we're not going to hold you to it, but what's your instinct or what's your initial reflections?
Well, it's interesting because the meeting I'm at a Red Cross Scientific Advisory Council meeting, and this question has come up about separate from, blood. That there's a need for a blood registry, So again, just separate from this exact question. Let me just back up to try to answer how we've looked at the Utstein template, right, specific to CARES. When we began the registry, that's exactly what we looked at. What are the existing data elements out there? We looked at Utstein, we looked at NEMSIS, we went to Seattle, we went to Boston, who had been collecting data, and said, show us how you're collecting the data. But ultimately, we're trying to collect, again, apples to apples approach. And that was the original intention of the Utstein template. Now, the Utstein template today there's a drowning template, there's a PEDS, neonatal resuscitation template. There's the idea, though, the biggest division at the time was really about traumatic versus non-traumatic arrest. Again, I know blood can be given for GI hemorrhage, right? So you could say it can be non-traumatic, but you have to look at what is the care from the dividing point between traumatic and non-traumatic. They're very different, right? I mean, why one patient goes to one side of the ER and surgeons come downstairs, right? It's a different entity. I think we all understand that. And if you're going to lump those cases, trauma with non-trauma, and the therapy is different, you're not really, you're kind of muddying the water, so to speak. So I think,
Yes.
so I think this is sort of a similar type question. Are you muddying the waters with a medical patient that's getting blood? If I understand the correction, right? This is like a GI hemorrhage that's getting blood and they're in a
Yes.
fib. Yeah. I'd say, how often do you think that happens across the country? Probably not frequently, but maybe more commonly in the future when you've got patients that, have a GI hemorrhage, you go there, you're giving them blood and they arrest, because you're meeting them
Yes.
at that moment in time. I don't have an exact answer because it's a non-trauma case, but I would say we do have a hemorrhage category in cares, a non exactly like a GI hemorrhage. So in theory, you could collect that patient if you, as long as you're saying it's a non-traumatic arrest,
Yeah.
and you would check off exsanguination as the category. So there is a medical category for hemorrhage for non-traumatic etiology today.
So let me use what you said. This is where I was going to try to direct this. Is Eric Bank? I'm about to pull you up. Yesterday afternoon, we were talking about creating a national registry for blood, as you brought up that you've heard about. There's a reason why, because Eric was the first person to deliver blood in the field here in the United States, and in his EMS system, and he's just been a great leader across the country in getting this done. And Eric, wasn't that interesting that yesterday, this is exactly, was it yesterday or the day before? I think yesterday, we were talking about this very subject about creating a thing that wasn't just trauma, that would be across the blood for those cases in which we're giving blood or blood products in the field, correct?
Yeah, that's correct. And so we do participate in CARES. I think Mike is the state coordinator for Texas. And we actually have given blood on non-traumatic cardiac arrest for both GI bleed. The one that you kind of aren't sure of or what to classify it as is the shunts, right? Is a blown shunt a trauma or is it medical, right? It's kind of in the middle.
Yeah.
And so we've had one of those, and we've had somebody with actually severe varicose veins that arrested. We actually got that patient back. So it's an interesting concept, but I definitely agree that trauma patients shouldn't be included. It's a totally different classification. But we're at, I know Randy's on here too. I think we're at like 325 agencies in the US with Texas money shortly approaching. We're just waiting on state contracts and Florida, you guys working through that process as well. We're going to see that number increase. So I think you're going to see it become more of a regular treatment. It'd be interesting to see how AHA addresses this in the future as a treatment. But I guess that's my 5 cents, because you can't say 2 cents anymore because we don't make pennies.
Oh yeah. Well, it's okay. So it's we'll double nickel here with Randy, and Randy makes a great point, which is exactly where I was leading to, is that a lot of the cases where we're giving blood, it's almost like I'm thinking blood should be a separate registry, but we still create those different pathways in there, like you're suggesting, for OB, for GI bleeds and all that. Randy, any opinion on your end, Colonel Schaefer?
Yeah, I mean, it's almost a hemorrhagic shock registry.
Yeah, right.
It is really what we need. And then kind of, like you said, going down the pathways, we've got some very, very sick maternal hemorrhage. Even random, we had a trach patient who had some kind of issue with their trach and started hemorrhaging out of their trach. So there's a lot of medical and non-trauma uses out there.
Do we ever see it with, for example, tonsillectomies after surgery, right? So
Right.
Just occasionally.
Yeah. Sweet little Izzy is our post.
Yeah, exactly right. Well, that's my point. So I don't know, my preference is to go have a separate whole registry for the blood and have it, and then breaking down those components will be very interesting in my opinion. So for whatever it's worth. So Randy, anything else to report while I got you on? And on that end, in terms of collecting the data, we got 330, you're saying, something like that, agencies out there, ground agents giving blood.
325. I suspect there's a few more out there that I'm just not tracking. So if you take a look at the map and it's getting updated this week. If your agency's not on there, please let me know so we can add them.
Okay, good. All right. Anybody else want to pipe in about this concept that Brian that Keegan brought up to us? Okay, so
I mean, I'll just say quickly, this was a conversation I had yesterday, and CARES is very specific, right, to non-traumatic cardiac arrest. When you talk
yes.
about blood, right, you're talking about a lot of different patients now, and I think that may be the question, to this larger group across the country is, do you want to collect, a blood administration registry and then have a subcategory for medical trauma, et cetera? Because it really comes down to, what are you trying to accomplish? And if it's the administration of blood products across multiple patients, or is it specific to just trauma? Those are the types of things you need to, I think about, because CARES is a very, right, this is a very specific patient type, non-traumatic cardiac arrest. And that's the inclusion criteria. There's obviously exclusion criteria as well. If it's about blood administration, you're going to be talking about medical and trauma and many different conditions. And that might be the way to approach it, as opposed to, what about all these exceptions? Because there will be a lot of exceptions.
Yeah. All right. Well, anyways, I don't know if we have a definitive answer for you, Keegan, but I'm leaning towards keeping it as a separate issue and all that.
It sounded to me like Emory wants to do a blood registry.
Yes. Yeah.
I'm not, no, someone asked me this question yesterday, and I was like, well, there's a lot to think about here. And we've always been concerned about mission creep, but I think we'd be very happy to share lessons learned as a minimum in terms of what is CARES? It's exchanging an EMS record with a hospital record to track that patient from collapse to ideally discharge. And I think it's linking. That's really what the mousetrap is. It's linking those two records and trying to get a clinical outcome. So, people have asked, could you use this for stroke? Like, yeah, you could, but that would be a whole separate entity. We've been very focused on cardiac arrest.
Sorry about that. Not sure what that was. So I guess we better move on, but I think hopefully this is a good start. And if anybody else wants to pipe in on this, have opinion before I move on to the next topic. Okay. And then, hey, Eric, speaking of which, is that if we don't have time, I like to have you bring up the topic about the body cams next week, if that's okay. Is that all right?
Yeah.
Let's see, because I guess I'm running over time here a little bit in terms of getting a lot of people on. A couple of the other topics I want to talk about are field amputations. And then the other issue is have Meg give a really nice presentation that she did. Meg has moved on. And Meg, are you still working as an assistant medical director there in New Orleans?
I am, yeah. So my deputy medical director, Dr. David Rayburn, has stepped into the medical director role, and the chief of EMS has taken my position as director. So there's been just a little bit of a reorganization of our leadership, which I think will be great. And I'm stepping down into a very, very, very part-time emeritus deputy medical director role. So just helping with the transition and things like that.
Great. So meanwhile, you've been working with MD Ally, et cetera, as one alternative approach to you call, we haul, right, to the hospital. And you may still haul or tell people to go to other places. But if you give us an idea of what you've done so far, and just so people know to reach out to you if they need anything. I thought it'd be kind of a nice thing to do here, if you don't mind.
Yeah, thank you so much for the opportunity. So I've been.
Oh, and by the way, you weren't on, but we have made a great, kudos to you for becoming the EMS Medical Director of the Year.
Thank you so much for that. I really appreciate it.
I was so privileged because I was allowed to be at your table. Right. That was really cool to see everybody, your family come and so on. And I was just so happy for you. It's well deserved, as you know. So,
well, thank you so much for that, Paul. I really, really appreciate you and all of your support over the years. So I am stepping in to MD Ally, which is a wonderful, wonderful telehealth program for 911 and EMS. So the goal of MDLI is to get the right care to the right patient at the right time. And really the way they do that is by diverting the patients from 911. So the majority of the patients that MDLI treats come directly from 911. So using evidence-based EMD, those patients are siphoned off out of the 911 system and into a telehealth encounter with an emergency medicine physician within moments. That ER doctor then decides what kind of resources that patient needs. So, do they need just a prescription refill? Do they need mental health services? Community paramedicine? Do they need a free Uber ride to an urgent care? All of these things are opportunities to get those patients not just out of the EMS system, but out of the ERs, right? Our ERs are overcrowded. This contributes to increased wall time. All of these things have downstream effects. So getting those low acuity patients out of the emergency medicine system, so out of the ER and out of EMS is really, really helpful. What's interesting about MDLI is that there is a care concierge. This is like a patient navigator that also helps to make sure that that prescription delivery service gets to that patient, to make sure that their Uber ride gets to the patient and gets them to the hospital. So it's basically like if my aunt called me and said, "What do I do in the middle of the night?" You've got a care navigator who can help organize that care, in addition to seeing an emergency medicine physician within moments. So really, it's about navigating resources. The 911 telehealth is integrated into the existing 911 services. So there's not extra things that need to be logged into. This is all integrated into the existing CAD and the existing EPCR. There's real-time support with connectivity. There's a 15-second warm transfer, and we're able to translate into 240 languages. We work with very vulnerable populations, especially our frequent flyers or friendly faces, whichever you'd like to call them. So those patients that sometimes call, 15, 16 times a day, we've been very, very successful in getting those patients to call MDLI directly, and they're down to calling MDLI directly about 3 times a day instead of calling 911 15 times a day. So we're really, really proud of that. Something else that's really wonderful about this program is that we've been able to provide support during hurricanes. So with just 6 hours notice, we're able to ramp up a telehealth support program where we're not just caring for those low acuity patients, but we're caring for those high acuity patients when there is not a way to get those EMS agencies and EMS resources to those patients. So I think about New Orleans, where we have hurricanes quite often. If the winds are greater than 50 miles per hour, we go ahead and take those units off the road because it's not safe to have them out there. Well, what do we do with those patients that are still calling 911? In Lee County, we've been very successful in getting those patients to talk to an emergency medicine physician, again, within just moments, instead of just saying, "Hey, sorry, we can't send you any resources. Just, stay alive and call back after the winds die down," right? So we're able to get those patients at least someone who's able to speak to them quickly and do whatever they can with the resources that are available during the hurricane. This is really exciting to see. So in Lee County, we've seen significant savings. So Lee County EMS has saved $7.45 million with avoided EMS runs, saved unit hours. And then this is the money that the patient has saved. So the patients have saved about $8.5 million in total, considering the EMS fees and the ED fees. So this
Let
is
me
really
interrupt you
exciting
for
to
a
see.
second. let me interrupt you for a second. So over what period of time? Is this over 5 years, over 1 year, or what? Can
This
you
was
tell?
over a 2-year period.
Okay, thank you. So
Yes, great question. Great question.
I'm sorry to interrupt you. I just wanted to put that in
No,
perspective.
no, definitely great question. So people are really happy with this. Nobody ever wants to go to the ER. So
Right.
having people be treated at home, especially our elderly populations in Florida, keeping them out of the emergency room is very important. Keeping them out of, the harm's way of flu or COVID or other things that they might catch in the ER. So I know that was very quick. We wanted to make this Eagle speed, so that will be invited back. But if there are any questions, definitely let me know. You can reach out to me. I'm so grateful for the opportunity to talk about this really wonderful program.
So I'm going to throw a couple questions at you. First of
Yeah.
all, so just if you go through logistics of a call's coming in and we're routing it over to MDLI, and then you said we're going to send someone by Uber or somewhere. So who's actually literally paying for that Uber? Is it MDLI takes care of that's part of the service they provided? Then you guys recoup that back from the payers? Is that correct?
Yeah. So any transportation or services that MDLI provides, so whether it's a free Uber Health ride or a non-emergency transport, that's all taken care of by MDLI. There's no bill for that Uber. Like the patient doesn't have to pay for that Uber.
And then it raised the question, you said something that sort of got my attention, which was you said Uber Health or whatever. Are there designated Ubers for health transportation nowadays that I don't
There
know about?
are, yeah. So Uber Health, not to do a commercial for Uber Health now, but Uber Health does have opportunities for rides to the emergency department, rides to a PCP's office or an urgent care, and they do very well. There's also Uber Assist, where just like if you had your grandmother that you wanted to go and you would like walk to the door and like help them into the car and then walk them to their doctor's appointment. They have Uber Assist. And so it's like having your grandchild pick you up and drop you off at your doctor's appointment, which I think is really helpful, especially for our elderly patients.
Yeah, so like me, right? So that's good to know for me to know about.
And I think Josh has a question. Josh?
He does. I was going to go over to Josh Gaither in Tucson. How are you, Josh? Okay, great to hear from you.
Good. Hello, everybody. I just wanted to give kind of maybe the unbiased opinion on the product. For just full disclosure, I have no financial interest with MDLI. Tucson Fire Department has been working with them for the last 2 to 3 years. Chanel, Meg, and the team at MDLI have a great product from a medical director's perspective. It is the absolute easy button for us as medical directors to hit. We set up our dispatch assisted MDLI program about 2 years ago. Meg was great to work with as we set up that program. That setup went very smoothly. We now transfer well over 200 911 calls from dispatch directly to MDLI each month, which is a great load off of our system. So that's a direct savings of those hundreds of dispatches every month. And then we also do the paramedic initiated one. We've piloted that in two of our stations with great success. We'll implement it program wide the February 1st or 2nd. The result of that is just like Meg said, it's pretty impressive. We have one patient who we initiated transfer twice, and then subsequently that patient had 17 calls to MDLI where they would have called 911 instead. So I just wanted to lend that kind of personal experience to it. Meg does a great job with this, is great to work with. The other thing, and then I'll shut up, is that they're also quite happy to white label the program. We tell our patients, this is a Tucson Fire Department telehealth solution we're going to transfer you to. which is a great service for the city that you all might want to think about as you consider your options. So that's just my personal experience. I wanted to share
Yeah,
it with
that
you.
was great, Josh. It's great to have an
Thank you, Josh.
objective, objective, not getting any money for it, jumping in, like we try to emphasize here. But it's great. I was trying to, I just want to show that this is one of the various services that are out there that we could be looking at, et cetera. And then, so for example, I just saw Joe. I don't know, Johnette, did you chime in here and thought this is kind of interesting for you guys as well? And then I'm going to go to you, Jim Augustine, next. Hey, Johnette, are you there by any chance, or do you want to pipe in?
I am here.
Yep.
Thank you, Dr. Pepper. Yes, I think this is interesting because we've been having these discussions, and I think this is something we can use. I just texted our fire chief and said, "Hey, are you familiar with this?" So,
All right, great. Okay, good. Well, fantastic then. So anyways, and thanks for being on. I hope you learned something from today. It's been a fun event. Let me pull some people over. So thank you so much. Jim, since she was talking about Lee County, all those who may or may not know that Lee County was Lee County, Florida. And the medical director is some guy named Jim Augustine, right? So from what I understand, Jim, you want to make any comments?
Yeah, this has been a wonderful partnership which predated me. I also have no financial interest or anything else. I just have a wonderful working relationship with Meg and Chanel and the other leaders. They have come through with the programs that we needed in Lee County, both on a day-to-day basis. And then, as mentioned, we had a 6-hour run up to our hurricane here, Milton, where we needed to have the backup rather than just telling people we're not responding. So within 6 hours, they had the program set up, and we're transferring calls across that we otherwise would not have been able to respond to. They have a very high level of satisfaction amongst the patients who use them, and we're looking for ways to use them more.
One of the things that you brought up about the hurricane, but it's not just the hurricane. For example, on February 20th, we were all, you and I and various other people were on the phone talking about this new coronavirus that was coming out of China. and the guys from Italy and France hadn't heard anything, didn't see anything yet on February 20th. Although Pierre was saying something about young, healthy people losing their taste and smell stuff, right? But the next day was the 21st, and the first case was reported there, and then it went nuts because it was the middle of February. A lot of people in Italy had all these colds, so the Milan people, where it happened, I'm talking about tens and tens of thousands of calls coming into the 112 system. And so they created kind of a system like this. They sent a lot of the ICU doctors and public health doctors down to the 911 center. There's the public safety answering point area, and had them in there to field a lot of those calls because the worried well will call in. They saw the same thing in Brazil when they had that radiation exposure at the birthday party thing, 20 years ago, et cetera. And to have 100,000 people going into the emergency department. So it just was, so it's not just hurricanes, it's a lot of other disasters that will come along with worried well. To have that kind of mechanism set up is going to be, I think, helpful under those circumstances. So, Jim, let me ask you a question then, and maybe I could go back to Josh or anybody else. But along the way, was there something you learned and adapted? And then, Meg, you can answer that as well.
Yeah, there are a couple ways that we can get access to patients, which is really important. One is at the 911 center level. The second is at the level of the providers in the field. And one of the things we learned, counting on the patient to have a smartphone as the only method of communication doesn't give you the flexibility that you need for some patients. So we continue to learn in doing that with MD Ally.
Yeah. Okay. All right. And then Meg, anything else you guys have learned along the way, how to modify things or in your program?
I think the biggest thing that we've seen as maybe a pivot is, initially we were really focused on decreasing those low acuity patients, but really leaning into those high utilizers has been something that I wasn't expecting, but has really provided, we do 24-hour follow-up appointments with especially our high utilizers. Sometimes we do 2-hour follow-up appointments to make sure that those patients are cared for and feel supported, right? People call 911 because they feel like there's an emergency, and whether it's an actual emergency or not, that's what they experience. So really leaning into caring for the whole patient.
There are some cities where those high-end users are basically huge. I mean, it could be. I remember Jim was I'm in the middle blanking right now. Medical director of San Diego years ago. They are like 10% of their calls were coming from like 100 people, something ridiculous like that. And so that's interesting then to keep track of that. And then has it been a good financial model for you? Are the payers happy because they don't have to put all the money about the emergency department? And,
I think the payers are the ones that are really benefiting the most from this system. I mean, the patients are getting the right care and not having to go to the emergency room and getting the care they need at home. However, the payers are really saving a lot of money from this model.
Yeah. And the other things is that things that Peter Antevi and I. Oh, Peter just had his hand up. That's really funny, Peter. We found with our providers and the thing can do this, but also maybe you could do it over the telephone. Is talk about like people who are potential people who should go into hospice, or if they call and then we haul them to the emergency department, then they're disqualified from hospice. So that's another way. Peter, you want to talk about that real quickly? You had your hand up, so go ahead, talk about what you wanted to talk about.
Yeah, no, first, thanks for bringing this topic to the forefront again, and thanks to Meg and Jim for all that you're doing. What impressed me most about what they're doing is that they decided to focus one department at a time rather than the spray and pray mentality, right? Which is like,
yes,
let's try to appease everybody. They said no. EMS, you see one EMS system, you see one EMS system, and they recognize that. And they're going very methodically, meaning that their thought process is not, let's just try to make a bunch of money. It's actually, let's try to do the right thing. And I've been very impressed with the way that they've tackled everything.
So in a very methodical, thoughtful way, and then learning the lessons and applying them here, or learning how we have to adapt it in the new place. So that's good. But Peter, that was impressive what we did with the hospice patients, right?
Yeah.
Right.
And right. So that highlights the importance of this. So we had so many patients, and I forget the number. Paul was like, we had 479 calls for 911.
Yes.
That dropped to like 17.
Yes.
Just with something like this, where you actually brought to the patient rather than a fire engine or an ambulance to drive them somewhere, you brought someone to them that said, hey, I think you could be helped out by getting this new resource.
Yeah.
And then, oh, really? I have access to that and the federal government will pay for it? Yes. Okay. And then they stopped calling 911. And that's exactly what MD Ally.
Yeah, and there's all those mental health issues. I could go keep going, forever on all that.
Yes. Right.
Yeah. So
the future.
Here's speaking of the future, Terry Valenzuela, right? Come on, you had a hand up. And by the way, Meg, Kevin's asking if you're going to have a booth at NAMSP. Okay, just so you know.
Oh, great question, Kevin. There will not be a booth at NAMSP, but we will be there and taking meetings. So if you want to meet up or learn more there, just let me know.
So Meg Marino will be there herself. Okay, is that right? The medical director of the year herself will show up. That's so cool. Good. Terry, go ahead. What's your question or comment?
There's an incremental cost to those services. I was wondering, are the insurance companies compensating you for saving all that money and the patients, or are you sucking it up into your budget?
So I think that's probably a question that I don't have direct information about the financials as much as Chanel Fields, the CEO, does. But I will say that the health insurers are very excited and very motivated to work with us. And then,
of course they are. You're saving them a bunch of money.
Yeah. But I'll get back to you on that.
And the important thing from other people's perspective, such as Johnette and Peter, etc., with the crises we've had with the wall times, well, across the country, of course, but we just saw that directly when one hospital closed, et cetera. And this would be great for I think for Glenn Asada right now, what he's going through. But the point was is to protect the emergency departments as well as from being overcrowded, et cetera, is another kind of an important aspect to that, right? So,
Yes,
Josh,
absolutely.
Josh, you had your hand up.
Yeah, I was just going to add, I think it's really important for all of us as medical directors to partner with our payers on these initiatives. We've partnered with the Arizona Medicaid system, Access, and they help support this as a statewide initiative so that any EMS agency across the state has the opportunity to participate. And of course, it opens up funding opportunities that makes things a lot easier. So advocating with your Medicare, Medicaid partners at a state level has been very successful for us in getting this program up and running.
Okay. And then one more thing, any other lessons learned from your end, by the way?
I think it helped us a ton to implement in a stepwise fashion, implementing that 911 transfer first, followed by the paramedic initiated one, helped our paramedics to get on board and see that it's a successful program, patients enjoy it, and it helped that paramedic implementation a lot. So stepwise was key for us.
Okay, TV, and then Peter. Terry, remember we used to call you TV?
And my question to Josh is, all the people you're working with, is anybody putting any cash money into the fire department, EMS, or has the city council done any incremental appropriations?
We're very fortunate in Arizona to have a treat and refer program. EMS agencies can bill the standard BLS transport rate for patients that are referred to MD Ally. And currently our BLS transport rate is the same as our ALS transport rate. So we do get reimbursed for these calls at a fairly fair rate.
Okay.
Bravo.
Peter? Oh, sorry about that, Terry.
Done.
Yeah.
Okay, Terry, Peter, rather.
Yeah, so the comment that I would want to make is that I strongly feel that this needs to be a statewide type of initiative. To have MD Ally go to every single agency and try to get them on board and have the payer conversation again. The state knows how much money they're saving, that it would save the system if they implemented this. It's in the tens, if not hundreds of millions of dollars when you're talking about 20 million population in the state of Florida and all the 10 million New Yorkers that are coming next week. So I really believe that this should be state by state because of the financials that Terry's pointing to. I got to take this call.
So another issue I bring up to our chiefs and various people over the years, the decades, it seems like now, has been when you have such a system in place, you also help decrease the liability because there's sometimes cases in which the patients don't want to go to the emergency department, and we say you should go, and we try to talk them into it, and they won't go, and then next thing you know is they do die at home, and then the family sues you and all that kind of thing because you failed to take them in or whatever it might be. But in this case, does MD Ally pick up the liability because they're the ones making the disposition? It's at the physician level. Is that the case? Does that protect the city from that point of view?
That's a great medical legal question that I don't know the answer to, but I will say that MD Ally is, all of our physicians are insured and have medical malpractice, and we are happy to take any calls from any calls from EMS on the field. So if there is a high risk refusal, we're happy to take that call as well.
But it helps a little bit if you have an MD making that decision, that kind of thing. And so,
exactly.
But the answer is it does. All right. Just so you know. All right. But so let's now move on. Real quickly, I just wanted to bring over Chris Caldwell because he's going to have to step off pretty soon, if I remember correctly. And Chris, a quick report. Anybody else? We can always come back for more questions with Meg, and Meg will just be around anyway. So, which is really cool. And she put out her email there for you. But I wanted to catch people before they go off. Chris, anything to report out of San Francisco, etc.?
I would only just a very interesting side note. So as everybody knows, we're getting ready for the Super Bowl and Pro Bowl and all those fun NFL things coming up as a precursor to the World Cup stuff. But
Yeah.
so we have to put in our information for credentials and all that kind of stuff. And they say, we're gonna have to buff it up this year a little bit because maybe the president comes into town, and maybe, just maybe, Paul Pepe comes into town. So because of that, and only because of that,
Yes.
we had to give a whole lot more information, get credentialed, get background checked, all that kind of stuff. And you did take precedence over the president, so I'm just gonna throw that out there.
Yep.
But we are building up for all that. The Pro Bowl actually happens in San Francisco on Tuesday the 3rd. So the lesser important Super Bowl comes after that down in the Stanford area. But that's a lot of what we are building up for now.
What's the chances of the 49ers getting into that? They're going up to Seattle this weekend, right?
Not zero, but not a whole lot. Seattle kind of kicked our butt down here in
Yes.
San Francisco not long ago. So not too hopeful, but it's not zero.
Yeah, exactly. And actually, and Marin County has left me off the hook, so things are going really well for me out there. So thank you so much for helping finesse some of that. You're the best. Well, Chris, how about in the emergency department? How's people's mentality since you had your worker killed there?
Yeah, we're still coming out of that a bit, and we've unfortunately had a couple of follow-up violent issues, which not anywhere near to that level, but just reminders of how the environment that we're all in and that we face both in the field and in the emergency departments. And we had unfortunately a nurse fairly badly injured as a follow-up to that. So we are still in a number of different recovery phases and kind of relooking at how we look at security across the board.
Yeah.
We just found a backpack brought in with two guns in it, despite multiple sweeps on that one. So anyway, lots more to come from that, and we are learning as we go.
Hey, so I have to make a comment. I do have to make a comment to Dr. Schaefer, etc. It said here, "Go Niners." So it reminds me of that movie, Something About Mary. She goes, I'm a Niners. I always said I was a Niners fan, right? So it's great. So you're our Mary of the week. So it's great.
There you
Thanks a
go.
lot.
Born and bred. I lived in San Francisco in '95 when they won the Super Bowl. It was fun. Born and bred.
Oh God.
So we'll keep our hopes up. There's a chance, although it may not be a great one.
Seattle beat our JV team, so go Seahawks.
Hey, Randy, did you live in the city then?
I did. I did my undergrad in San Francisco.
Ah, no kidding. Okay, where'd you live there? Just out of curiosity.
On campus where all the other poor college students lived at University of San Francisco.
Okay, yeah, I was in the Inner Sunset. That's what I was asking, since that's over on that side of town.
I took the 5-year plan through, so I had extra time in San Francisco.
Okay, good. Terry, you had a hand up again?
Yeah, Chris, back in the Jurassic General, there was a county sheriff deputy in the ER at all times. Is that still true?
Yeah, we actually have quite a few sheriff deputies in the ED.
Yes.
That what we're challenged with is sheriff deputies don't do hospital security. And the real, and this has been our big point of discussion that's gone to the city level and beyond, is to what degree can we rely on law enforcement, particularly now. Yeah, in the old days, it felt like that was something that we could really absorb, but now they are very clear. This is what I will do. This is what I will not do. And right now, our only option is deputies. And I got to say that puts us at actually increased risk, because the patients that they bring to us in the emergency department are not necessarily law enforcement issues. These are many other issues with mental health and other things that they will not intervene on. So that's been actually the biggest challenge, despite their presence.
Yeah.
30 years ago, there was an ER nurse who was being assaulted and took out a gun that nobody knew he had and shot the patient.
Oh, where was this?
So, this is San Francisco General.
Yeah.
Back in the Jurassic.
Yeah, back in the Jurassic.
The nurses will take it into their own hands.
Yeah, I would. You don't even. Well, Chris has heard some of my stories from the General from way back. Mission Emergency, right? So, wow. Yeah. So, okay. Well, let's move on to other topics that we have. As I said, I may not be able to get on to the one of the ones, but I'm thinking about several of these things to end up being more larger scale, maybe more panels. There's like 60 or 70 of us to give lectures, and we're always trying to force it and all that. And it may just be that we bring up some certain topics and expand, Eagle Creek into more of a thing where we have discussions on these levels about these various topics that we are bringing up today. One of the ones that's been kind of interest to us here recently, just because of a case that came up in Broward County, has been related to amputations, and they wanted to know what is there classes out there? Are there things where we actually are we always going to send a doctor out there? And do they have to be a trauma surgeon or orthopedic person? Can we be an emergency physician? Can we be an EMS physician? Or even can a emergency physician be there on scene, but you're in claustrophobia land or you're in acrophobia land, and so maybe they won't do it, or can they direct another person, delegate the practice of the amputation to someone who's a technical rescue person, etc. So a lot of interesting questions that have been raised, and I'd like to know what's going on around the country. But let's start off first of all with Jim Augustine discussing some of the stuff, and then I want to go over to Mark Gautreaux and talk about actually the training classes he's been putting on. Okay, and if you don't mind, does that sound like an interesting thing to get into here? Jim, what do you think?
I think it's a thrilling area to get into.
Okay.
Because we've had to deal with this a lot.
All right, so it's going to be a first there, first care, and maybe we'll have it expanded into the first there, first care side, not just the Eagle Creek. Okay, maybe that's something that we can make as a topic. Okay, go ahead.
Yeah. So it's both an issue for EMS and then for our surgical emergency response teams, which generally are set up to do that. Then there's two elements. How do you manage a scene? How do you get a helicopter and a surgical team into the site safely? How do you manage the victim? How do you manage the amputated part? And then what happens if you can't amputate and you can't take the machine apart? So we've run across all of those already. There's a few people that have done this that are amongst the Eagles, and I've one of them who's been part of this. So we have.
Jim, I want to set it up too, and to emphasize that some of the things that people don't think about, they just think it's going out there, we're going to saw someone's leg off or whatever, is that a lot of these things occur in really like in a ditch, in a claustrophobic, or a collapse like what we saw with Joe Wackerly did it, remember, at the Fall Down Hyatt in Kansas City. And we had, but there's been situations where I've had in a bakery area, a big auger, and the flour is all there. And if you try to use a saw there, it creates sparks, and the whole thing would blow up. We got to have. First of all, it's not just a medical issue; it's a technical rescue issue as well. Correct? Just to set this up. Yeah.
There's a lot of technical elements, and there's a whole program in fire called Man and Machine, and they specialize in talking about taking the machine apart rather than taking the patient apart. But there's a lot of life-threatening situations, and I'll give those agricultural and other vehicle-related, where you've got a critically ill patient and they're trapped by one of their extremities, and you got to get them out. Thank goodness Craig Manifold set us up for the Eagles amputation lab that we did 1 year. And we learned about the difficulties of that from a surgeon who worked in the war zones, because they were faced with the same issues there. So, Paul, there's a lot of interesting elements to it. There's typically case references, because many of these cases are so individualized. And there's an issue. Dave Kessig and I wrote an article on this in GEMS, and promptly the state medical director of a certain state said we were personally liable for writing such an article if a paramedic attempted to do such a procedure in the field, which is beyond their scope of practice. So let's just say there's people out there who are not fond of any idea which takes paramedic beyond their scope. But there are certainly situations where surgeons and orthopedic surgeons don't want to climb into machines, get up on the top. A lot of these are in the wrecking yards, and a lot of the published cases are in wrecking yards. And though, you're climbing up on the top of some apparatus. And again, very much the job of the fire department is to provide a safe work environment. So whether it's flour or sugar or sparks related in the area of the gasoline, they're certainly seen safety issues.
Yeah. Okay. So, and so that's what I want to totally emphasize as we get into it. It's not just a protocol that let's go out and cut or who we're going to send and all that kind of thing. I have a feeling that the protocols are different across the country. And one specific issue I wanted to find out is that, like, for example, I think it would be easier to do in Florida and Texas because we have delegated practice. I can say I'm taking what do you call it? The right word here. I'm taking uh, all accountability for this procedure, and I'm going to walk them through it, et cetera, as needed. So, any event, but because I think that there are going to be so many situations, as you alluded, Jim, where they won't be able to do it themselves, or can't do it, or probably shouldn't do it, in some respects, depending on the situation. So I want to find out, does anybody have a thing where there can be delegated practice in that sense, or set it up, or have had experience with that? Anybody on the call here today?
Got a couple of chat notes from LA County and Toronto, Paul.
Okay, got it. Okay, so go ahead, Mike, then in Toronto, then I'll go back to you, Mark, in a second.
Yeah, we would not delegate this to the paramedics simply because it's so far outside anything they've ever trained to do. We do, however, have a pretty robust roster of HUSAR physicians who have been trained to work in confined spaces with our heavy urban search and rescue team. And every HUSAR exercise we do usually includes an opportunity to do a field amputation, and the doctors get really dirty and sweaty in these uncomfortable spaces. The blood bank provides all kinds of blood products on short notice, not just whole blood but any blood components we need. I've never actually cut a limb off, but I've gone to a half dozen of these, and either the patient had just died or we stabilized them and were able to extricate them because we bought them time.
Yeah. Okay. And let me ask you this, because I don't speak French. What's HUSAR? Okay.
Heavy urban search and rescue.
That's what I thought. Okay, good. I wanted to make sure people knew what that was.
Like Florida Task Force One, or this was set up in Canada after 9/11, and sooner or later Vancouver is going to fall into the ocean, and they'll need the Toronto team out there.
And several of the situation I've got is, as you pointed out, is that we were thinking that we had to do the amputation, had people out there, but we were able to use other tools such as the JAWS to open up the auger situation, as I said, and various things. So yeah, there may be things, but you're just getting ready to do it. But I think the idea about training ahead of time, and would you guys train, for example, if you're cutting through a leg, do you train on how to control bleeding and all those kinds of things afterwards, and are prepared to do so? Are those kits set up that way?
We really, the bleeding control is, unfortunately, we rely heavily on tourniquets and hemostatic dressings and so on. So we usually apply 2 tourniquets. But I've been also called for ones where they wanted me to amputate, at a junction like the pelvis, and I'm like
yes,
I can't do a corpectomy for you guys. It's like I cannot amputate there, and those are tragic.
Yeah. Randy, since you've been out there in the war zone and had to see a lot of cases, any comments about here or anything relevant to our discussion here?
I'll be honest, if you are that bad off in the war zone, if it's less cold zone, you're not going to send out teams. I've done like amputations with my trauma shears, but that's about the level. Unless it's the kinetic environment has absolutely stopped. We're not able to do that.
Okay, good.
Dallas is supposed to have a pretty good team. They published a few years ago.
Huh?
Dallas has a team. I think they had an article called "A Call to Arms," which was a good
that's right. Yeah, we went on a limb there to write that. Yeah, that was based on some of the cases that I had just mentioned to you that I had to go through. Let's go to Mark Gautreaux out there in San Jose. And so you tell a little bit about what you told us the other day about how you're doing trainings for the residents, I believe. Is that correct?
Yeah, so I've actually been thinking about this issue for a number of years now, and it actually was brought to me by our USAR team after an incident where the protocol in Santa Clara County was for a police officer or an EMS supervisor to pick up a trauma team from the hospital and bring them to the scene.
Right.
And the difficulty is that the trauma team, arrived on scene wearing scrubs and Crocs and had no idea how to conduct themselves outside the hospital environment.
Yeah, I'm
And
gonna tell you, in the last 2 days, I heard about the Crocs thing
yeah.
locally here. That's so funny you said that. So
And so as
cracked me up.
somebody pointed out, it's as if you took the entire OSHA manual and said, this is your violation. So my concern with that was also, by the way, it just removed that trauma hospital from being a trauma hospital because the team was gone. And of course, in California, we also have the potential for, earthquakes where we may have
Lots of people pinned,
lots
yeah.
of people. And how often do you want to send either your emergency physicians or your trauma surgeons out of the hospital after a major event like that? I like the idea of USAR trained physicians, but we have USAR trained physicians. They're all in my division, and we are frequently either away or on duty all at the same time. And so we're not available to respond immediately to an event, guaranteed. Um, and by the way, no one is experiencing this anywhere in the world. You know, some people have done one, maybe a handful of people in the world have done two. They're the sort of the weirdly unlucky people. And so it's technically not a difficult procedure. You can watch a YouTube video and learn how to do it in 7 minutes. So what we did, I was approached by the residency program to say that the residents had requested something other than just a tabletop exercise for their mandatory disaster day. So I arranged with the fire department to bring them all down to the training center, and we did a bunch of disaster type scenarios, including some vehicle extrications, and we ended up purchasing a bunch of cadaver limbs that were fresh and supplied by a specialty company, and had the residents and the USAR medics all practicing field amputations under a simulated environment. Most popular training that's ever been conducted by either the residents or the USAR medics.
Yeah.
And so it's still not in scope of practice, obviously, and especially in California, where, I mean, we don't have, RSI in scope of practice. And I think that the difficult part of the procedure is the decision to move forward with the procedure. And so, we are continuing to explore, different scenarios in which we would engage either online medical control via a telemedicine link, or, to help with the decision making.
Yeah.
And potentially communicate with both the provider and the patient through a telemedicine link. But I remain convinced that the person actually holding the tools probably needs to be a USAR trained paramedic who can get into the scene safely, get into the space that the patient is trapped in safely, and who is available, on duty 24/7, unlike us.
Yeah. So, it's may or may not be a strange thing for me to bring up, but it comes up and it's so uncommon. But if you're not prepared for it, and particularly if you haven't done a lot of them, I don't know if it's going to go well, etc. But then if you don't understand all the complexities of this, as Jim was alluding, we got to at least be thinking about it. And I'm glad that people like Mike has been able to tell us that a lot of times you don't have to do it, but you're prepared to do it, etc. But I'd like to, I don't know, do you think this is a worthwhile topic to go into and dive into then at Eagles, or just say it's one of those things that just doesn't happen that often? Anybody have an opinion?
It was interesting when we got to do it in the lab, and Craig organized that, and the physicians learned the complexity of it. And for us, this is one way where, as Mark is pointing out, you really have to integrate the work of your team. If I were a California physician, this is going to happen someday in an earthquake where you've got, dozens to hundreds of people that are trapped in cars on a bridge that has collapsed, or buildings that have collapsed. So this would be the USAR type of people.
Yeah.
I for one would love to hear her talk about this and share experiences.
Okay. So let me consider. I just don't want to waste everybody's time if it's something that's going to be so rare that you're never going to have to do it. I don't want to be esoteric, but maybe it's still of interest. So that's great. Do you remember Joe Wackerly doing it at the Hyatt, and he ended up being major players. And then Ron Stewart, of course, classic, when he was up the crane that time in Pittsburgh. That was another interesting time, etc. So a lot of our well-known characters in our field did get to do these things. So it's interesting. All right, so let's do.
They had multiples at the Hyatt, Paul.
Yeah, exactly right.
Yeah, they had multiple people that they had to cut out.
So that's actually brings up what Mark said is really important, because if they do have an earthquake, that's going to be a big issue there. So I agree with that, and maybe that's something we should push a little further on, especially in California and other prone places. Yeah. All right, so let's Ben Launer, do you want to make a comment and tell us a little bit about how your system works and why it's different, maybe?
Yeah, this is a really interesting point, because I feel like I'll probably get fired by the shock trauma gods. But in 1980s, R. Adams Kelly had this idea, and this was the original purpose of the Go team. We want to be able to cut legs off. And what's interesting is we haven't done one of them in 15 to 17 years. That does not mitigate, I think, as Jim said, the presence of physician response. I think the key here is it is really done best by people that are training within a particular system. So all I can say, and I'm happy to have a discussion with this, we reviewed the data. Really, the fact that EMS is sedating people, doing RSI and giving blood has really extended the resuscitation time. So if EMS is doing their job, it's very unusual for this to happen. One of the things that we've seen is, and it's a fascinating discussion, is we can liberate a trauma surgeon sometimes, an emergency physician, but not the CRNAs. So really now we have a physician cohort, which is ironically mostly EMS physicians, that goes through the USAR type of curriculum. We do a cadaver lab, but it is like shockingly infrequent for the time that we train. And we find the Go team, there's some published data on this, but of all the times we've deployed, it is just frighteningly infrequent the time that we're actually cutting off legs. I do feel the best discussion here is about how best to integrate, because that's where you get the problem is you have a trauma team from offsite, and then, they're not familiar with the scene operations and who does what and what's medically directed rescue.
What kind of shoes to wear, right?
Right. But I think they deploy centrally with a kit. And ironically, the equipment that's been used, most of the time you just need a scalpel, because it's not usually a huge limb that's entrapped. But we carry jiggly saws and then the reciprocating saws that are carried by all the technical rescue people.
Okay. All right. Well, okay. That's probably enough of this. We only have a few minutes left. I'd love to go around the room still. I don't know if we'll have time to, but we'll give it a shot. But hopefully this will be interesting. And then, Eric, we're going to come back. I want to resurrect the issue of body cams for EMS. And it's going to be, I think, an interesting thing. You'll see why. And we got a lot of good data now coming in from some places. And so we'll bring that up next week. So let me, anybody else have any other things to bring up before I quickly go around the room and see, especially talk to some of the people we haven't talked to for a while, etc. I hope this was an interesting day for you so far. CME, as you heard before, was 23070. 23070. Oh, no, 71, right? 71, correct?
71. Yeah, Seagulls was 70.
Okay, got it. Yeah, 23071. Okay, good. All right. So, hey, with Ben, since I had you on, anything to report out of Baltimore while I had you there? And I'm going to go Crawford up the road.
Nope, still the usual stuff. We're off to I think Nurse Nav for the year. We're up to about 392 calls. Still ongoing discussions about blood, but other than that, nothing too much to report from Baltimore.
Got a very nice New Year's thing from Amal. Couldn't make it today, but just tell him thanks and how good he was to Ray and I and all that. When we came.
Absolutely, we'll do.
Okay. And by the way, let me jump ahead to Kevin Mackey. Well, let's go to Crawford first. I'll go to Kevin Mackey. Crawford, anything report out of Philadelphia?
Not really. We're getting our new deputy medical directors and associate medical directors kind of settled in and trying to figure out who's doing what. And otherwise, I'm starting to feel like Terry in the sense that having done this a long time, the same topics come up over and over again, like the whole field amputation thing. And the last time it came up, no one was really quite clear of a definitive way of addressing this and sustaining a program and stuff like that.
It will be the same 25 years from now.
Yep.
What was that old? I think it was Dwight. It would sound like a Yogi Berraism, but it was from Dwight Eisenhower. He said, "Things are more the same today than they ever have been." Right?
Yes, exactly.
All right. Anything else, then, Crawford?
Nah, I don't. Nice to
Okay.
see everyone.
Okay. So, let's see. Who was I just? Oh, Kevin Mackey. You still there, by the way?
Yeah, Paul, I'm still here.
Yeah. Anything you wanted to comment on, either from the NMSP thing or from? I mean, everybody knows we're going there to Pirate City, and I've been practicing my args, and so be it. We'll keel haul every last one of them. Arg, right? Right.
Right. Bring your rum, your eye patch, and your peg leg, and it will be a
Yeah.
great time.
Both of them.
Both of them, right?
Yeah,
Exactly.
right. Okay. Anyway, so anything to report out of Sacramento? You're always doing some cool things out there.
Probably the biggest thing, and maybe we'll talk offline about whether or not this would be interesting at First There First Care, which is we have grabbed some social workers who are looking for work, who are contracted by our county, and we've launched a very robust crisis response team.
Yeah,
And been
okay.
able to do de-escalations in the field and navigation directly to psychiatric centers. San Francisco places 5150s with their paramedics. We don't do that yet, but we do now have a resource that can do that. So it'd be interesting to talk about having a social worker implemented into your local system if you're interested in that.
Yeah, no, very interesting. I'm sort of almost been assigned by, I'm a direct report to the county commissioners in Dallas, and they really want me to get on top of that more, and particularly some of the outlying, help some of the outlying states. But there's the thing we've seen, and I went out and worked with, I've been in Memphis with Joe. They started great programs for this there with I could Stein, I could go on, and learned a lot with Mark Cohen too. And so just a lot of interesting programs are out there, and a lot of them are all different, and which may be appropriate because you have to adapt it to your city and your personnel and what you have. But what we're finding is that there's been not a either lack of either social workers or attrition, that goes on there. And so that's one thing, talking about how we're going to handle that long term, and maybe using other personnel and not social workers for it. But I may come out and visit with you then, and any excuse to have dinner with you and Mary. Okay, since you had such great taste in wine, I'll come out and check out your program. But I think it's a great thing to bring up at First There First Care. Okay. And see what the different models are that are out there and how they work and what the issues have been. That's what I want to learn from you as well.
I'd
Okay?
be curious if I can get our social worker to come with me, and then it'd be interesting to hear from her from the stage about her perspective about
Yes.
working with a fire agency.
Yeah. Mark, that might be a good thing to do with your folks. It was interesting. I got to have fun and meet his people in Beverly Hills as well as out in the county, right? That kind of thing.
Mhm.
And Mark, what do you think? Same thing?
Yeah, it's I think again, every system is different. The program I've got in Beverly Hills is very well funded, well resourced, and very different than what we've tried to do in a couple of other systems. So just the scope of problems and the time they have to deal with them makes Beverly Hills just a lot more successful. I will say the most success we've had there is bringing it's not human resources, like human services under the fire department. So the city social workers are now part of the department, which makes them not just part of the team, but also beholden to department initiatives. So when the chief asks them to do something, it gets done, as opposed to the independent ones that we were working with and the contract ones that we were working with that were getting paid by the hour and couldn't care less. So it's been a very good experience there. I think, again, it's scalable, but it has to be adapted to the environment and city and the community. I see you've got your hand up before moving on that. Just also want to throw back real quick to the field amputation stuff. I put in the chat, there's a paper that we wrote here in LA a couple of years ago based on one of our experiences. LA has had the hospital response team for since I think 92 was when the initial policy was written. But it wasn't until about 10 years ago that we had our first actual field amputation. There's been less than I would say a half dozen since then. So it's definitely the kind of thing where there will be patients that will benefit. The resources that are needed, very hard to muster and keep active and keep trained, except in a very large system. We've got 2 level 1 trauma centers, academic trauma centers, that have contributed the staff personnel training, and it's worked okay here. But I think for just a regular community-based system as opposed to the academic, it is quite a lift. But again, it's worthwhile, and I still feel guilty saying it was my best day of EMS being on the or in the field for the actual case. So
yeah, well, listen, actually, I'll be asking you guys soon for topics they want me to start earlier, and we keep each other up to date. That's the most important thing. But I'll make sure you put that down as a possible, a discussion. Remind me, because I remember all you guys here on the call today who were, having their contribution here, whether it's Jim or Ben or Mark or whatever I really appreciate that, Ben. And we'll do the same thing for this issue about handling social service cases. Let me put it, that's a nice way of putting it for now. Stein, you had your hand up. Is that, or did you lower it because it was up so long and you got tired, or?
No, I just hate leaving it up and forgetting to take it down. So,
okay.
I know we don't have time now, but I'd love to participate in the conversation about the social workers and everything.
Yes.
And, Paul, you came out and did the law enforcement CIT class and everything. And we also just were able to hire on social workers for the fire department that work for the fire department, which really changes.
There you go.
Tremendous elements of having to navigate through independent services that own the social workers and all their rules and regulations. And, so it's a great conversation.
I see a new topic showing up for first care besides amputations and all that. So that's great. All right, good. And I want to hear about everybody's different models. So that's it. So remind me about that as well, Kevin. So as we get through it. All right, let me quickly try to go through the list and see if there are people you haven't talked to for a while. And John Jew, there you go. You've never had any cases, but you do have a field amputation team set up as well there, right?
Yeah, we have, and we're actually exercising this. Very similar to Mark. We have a outstanding group of our trauma surgeons and emergency medicine residents, but we're scared they're going to show up in Crocs as well. So I actually think that we're trying to educate them as yeah. So yeah, Portland uses Crocs a lot. Anyway, we also had I've gone through the 40-hour USAR course. I think the combination of the following: a USAR trained medic, who he or she is used to the operational aspect and most importantly, the hazards, and working with a team in combination with the EMS medical director, is probably the best, I would say, field operational experience. Does that make sense? The other issue is I think with the advent of this is single incident. In other words, it's not a disaster. Most of our entrapments are with tractors and things like that. Does that make sense as well? And so I actually think that telehealth with a surgeon who can't leave the ER is one really very important. In other words, if there's a doc there that actually knows, especially a faculty, we can actually have a video camera that's confidential. We can say, this is where this is where we're going to amputate. Are you okay with this? Does that make sense? I think the skill in amputation, I've been through the course, straightforward. Honestly, I think the use of the ghillie saw is sort of medieval. And my firefighters said, they would pull out the reciprocal saw and say, Doc, why are you hassling with this? It's like, I just got a better saw. But anyway, I think it's a rarely used facility, but I actually think that we should operationalize with telehealth when feasible with our USAR trained medic. The worst, most of our amputations, at least some simulated amputations, have been open, not in a trench. But I think so it depends upon the situation. Back to you, Paul.
Okay, got it. Hey, Dr. Smarty is on an airplane right now. Could report anything but note that we need to know about?
Yeah. Fortunately, there is an outbreak of what's called XDR Shigella. Fortunately, is in Los Angeles. So I want basically for the San Francisco colleagues, Mark, to stop it there. We don't need that here as well. And the XDR is basically it's a very resistant organism that's resistant to the third and fourth generation cephalosporin. So it's it's obviously very contagious in probably the houseless, homeless population, but it's of concern for us right now. Everybody knows we're in an outbreak of flu and measles. There's nothing really new about that.
One thing that's very interesting, I think they think I'm off my call. I'll just set the voice, but I think they think I'm finished. I told them to call me afternoon. Central. Hey, so what I was going to say was that I saw a really interesting article that a lot of times you'll see measles in the sewage system, long before you start to see it at the population. So that's an interesting thing that everybody's monitoring now, right? So is that correct?
Yeah, we had a measles went into a person in a county south of us, so it's in our area right now. So I expect that to be a problem. From a EMS medical director point of view, I don't think measles is going to be a problem, except for the workforce. A lot of our workforce is not vaccinated or it has very poor vaccination records.
Really?
And they're out of action for 3 to 4 weeks because of the incubation period of measles. So it's really, at a minimum, each medical director should have your agency check the vaccination records of your personnel. If they don't have good vaccination records, our health officers are going to take them out of action.
Okay, that's interesting in itself. So thank you so much. There aren't too many people left over. I don't know if anybody just wants to pipe in. Josh, anything you want to tell? Oh, it's just like Josh pops up when I was going to call on him.
Perfect. I was actually just going to second what John said about measles. We did have a measles case this week that was transported by our agency. The only thing that kept our providers at work was their current vaccinations. And thankfully, our safety group at TFD does a fabulous job of ensuring everything's up to date and documented. So those folks were able to go right back to work. So current vaccination and records will keep your crews out there and working. That's all I got.
Okay, good. Nothing new other than that out in Tucson at this point in time then. So I understand we have a new medical director. Is it Aaron Eberhardt up in Phoenix? Is that right? Do you know him, Josh?
No, I love Aaron. He was my co-fellow in Denver. I believe he still works in Denver. I actually don't know who the current Phoenix Fire Medical Director is, though, but I can let you know.
Okay, got it. Oh, maybe Aaron's coming in, and that's right. Maybe he's coming into Denver. I think it's Charles Finch. Do you know that? I just got the cities mixed up because I got these names together last night. So, do you know Charles Finch? Does that sound
Yeah,
familiar?
it could be. Yeah, that could be correct.
Yeah. I don't know if you want to sort of, just plug him in with me or whatever.
Yeah.
I'll try to track him
happy
down.
to.
I appreciate that. So, okay, that's great. And then, yeah, that's right. So Aaron is in Denver. Okay, good. And then I think we have a new person in Kansas City as well. And then in New Orleans, as Meg said, we have that new person, Dave, is there. Okay. So yeah, I got to sort of start getting everybody and introducing them and sort of do their initiations into the Eagles, right? That kind of thing. Okay. Hey, Roger, anything in your city? And then Shuri, I was going to say something to you in a second, but I got to get going here. So
yeah. So just on the discussion of USAR, we happen to be the host of Maryland Task Force 1. Used to be exclusively us, but now we've added Howard, Anne Arundel, Prince George's County, Maryland Fire, and DC Fire have all joined our consolidated team. And we have quarterly training. And every so often, that quarterly training, rather than being a discipline separately, we have multidisciplinary like drills. And one of the last ones we had was with rescue. We create scenarios all day long. And then we always incorporate the amputation scenario so that we can get practice on it, even notwithstanding the fact that it's a very rare thing. So that is something. I did want to ask Crawford. I received some news that there was a medical director out of Montgomery County, Pennsylvania, which is suburban, named Dino Gualtieri, and I didn't know if some of the folks had known, but there was an announcement of his untimely passing, and I didn't know if Crawford had known him. I'm wondering if he's known to Ed Dickinson too, who's at HUP and has been a pretty well-known emergency physician in the Philadelphia area. But I wanted to pass along that sad news. Crawford, do you know Dino?
No, I don't, but I'm surrounded by people who do, and it was very sudden and a big hit. It sounded like, so kind of very sad news.
Yeah.
Okay.
Yeah. And then the only other thing is duty officer classes we have those periodically, and so we have new EMS supervisors that are part-time that are all trained in all of our enhanced things like ultrasound and vents and whole blood. So we're expanding our cadre of folks. That's just in the last week. So that's everything.
All right. That's it. Libby, anything out of Hawaii that we should know about?
Nope, all stable here. Thanks.
Let's go to another island, like the Emerald Isle. Mick, anything to report out of your shop?
Nothing specifically, just interested in that conversation about the field amputation. So we had a thing about 2 decades ago where a coroner had suggested that family practitioners in the field could be directed by the local surgeons in the hospital over phone to conduct field amputations, which then resulted in a little bit of a rushed scenario to try and create these hospital response teams who would go out to perform field amputations.
Got it.
Over a period of about 15 years, that message was kind of lost. And the junior residents in the hospital were all delighted to be attached to this field hospital team and didn't realize that the only job they had to get there was to do an amputation in the field. And we went, you know, the role when you get here is to do an amputation. No, I can't do that. We had to reverse back the whole way and go, we're never doing these things. It's not going to happen.
Yeah. Okay. Interesting. All right. Hey, listen, Cherie, thanks for being on, and hope you can get on pretty regularly with us and give us some reports maybe next time, if you don't mind, give us an update.
Yeah, happy to do that.
And to answer your question, I will be in Tampa in 2 weeks, but usually in the lobby. I don't attend the meetings and can't afford, I'll be very blunt, can't afford the tuition. So but I'll be out there and I'll see you. Okay, and catch up.
Excellent. I'll catch you in a lobby.
Yeah, I heard that things are exciting there in New York with all the nurses' strikes. So Glenn was on. You hear the part where Glenn was reporting about that earlier in the call?
Yeah, no, I missed that, but I hear this is a long haul and too reminiscent of a couple years ago when Sinai went through
Yeah, this is
the
gonna be
same
worse.
thing. So
And then my guess is this is going to be a lot worse and all that.
yeah,
All right. I don't
exactly.
know if I missed anybody or whatever. Is anybody else want to pipe in before I shut us off? Because I got to roll. I'm late for a meeting. So, okay. If not, I hope this was an interesting meeting to you. Like I think I did. What was the title of the thing I put out there? And I said something like too many talks. So I was right. But they were good. They were fun. They were fun talks and good conversation here. So thank you very much, everybody. I love the contributions. And it sounds like the thing Kevin Mackey was talking about and Stein and so on and Mark is going to be a great topic to delve into as well. So as we get together this summer. Okay. All right. Well, thanks a lot, everyone. Take care. Bye-bye.
Yeah.
Welcome back, my friends, to the show that never ends. Next Friday, the 23rd.